But I want to say welcome and thank you all so much for joining this webinar. We're hopeful that I'm sure that you will get some good hints and tips to take back to practice to make a difference to the integrity of your patient's skin. So our webinar today is called Protecting Skin Integrity, the Key to Prevented Moisture Associated Skin Damage, or MASD, and we'll be with you until 2 o'clock this afternoon.
Great.
Lovely. Can we go on to the next slide? Lovely. This is me. Let's go on off of this slide fairly quickly. I'm Julie. I'm one of these senior clinical nurse advisors, and I'm the DJ today. I get the fluffy fun bit. The person doing all of the work is Emily, who is one of our excellent clinical nurse advisors. She's a superstar, so she will be presenting the webinar for you today. And I'll be in the background just to help with any questions or any challenges that you have, really. Thanks, Emily. So as we said, this is a 1-hour session. Now we'd like you to ask lots of questions and don't be afraid to challenge. So if you feel, oh, that's really interesting, I want to find out a bit more about that, or actually I've read something different to that, then please pop a note in the chat box for us. I'll show you how to do that in a second. At the end of today, you'll all get a certificate. What we need to do in order to be able to give you a certificate is to ask you to give us some feedback. So we'll provide you a link at the end in the chat box that you can just click on, fill in the feedback form, and that will automatically generate your certificate. So you will get your certificate at the end of the session. Thanks, Emily. So this is your chat bar at the front, at the top of your screen, okay? What we want you to do is stay on mute for most of the session because there's a lot of people with us today. So we'd like you to keep your microphones muted. If you want to have your cameras on, that would be lovely, but it's entirely up to you. If you have any patient discussions or any questions about patients, please keep them generic and remember patient confidentiality and don't share any images, etc. of patients. Okay. We do have a Q&A icon, which is at the top just next to the chat bar. So if you've got a question or a comment, please put it in the Q&A icon so that we don't miss it at the end. Okay, so please feel free to do that. If you have a burning question that can't wait till the end, please raise your hand. But for the majority of questions, we would like them in the Q&A just purely because there's so many people with us today. Feel free to react as we go through and watch up for pop-up boxes because we're going to poll you as we go through and ask you lots of questions. They're not tough, they're not difficult. It's just really about really gaining your opinion and your understanding of some of the issues that we're going to be talking about today. Thanks, Emily. So please adhere to your local formulary guidelines. Remember, we're from different areas of the country on the webinar, and we all have slightly different pathways. So always follow your clinical pathway when it comes to protecting the skin. Most importantly, we hope you enjoy the session today and get some hints and tips on improving the outcomes for your patients. I'm now going to pass you on to Emily, who's our wonderful clinical nurse advisor, who will take you through the presentation. Thank you all for listening.
Thank you, Julie. Thank you so much. Hello, good afternoon, everyone. I'm Emily, and we're going to talk a little bit about prevention today, prevention of moisture-associated skin damage. So what we're going to do first is just briefly go over some kind of learning outcomes and what we're going to achieve. So we're going to briefly talk about what moisture-associated skin damage is, but we're going to look at the different severities, how we categorise that level of damage, and also the classifications, so different types of moisture-associated skin damage. We're going to talk about risk factors and how those risk factors could be the key part of identifying any damage before those signs and symptoms are there, okay? So we're really focusing on protecting skin integrity and preventing infections and other complications that might arise. We're going to talk about barrier creams and how they can't really be replaced, but how they can kind of be compared with emollients. But we'll talk about when is the right time to use both, okay? And then we're going to lastly look at the components of effective skin regime that really supports barrier function so we can prevent any moisture-associated skin damage. So let's look at what moisture-associated skin damage is first. So you might have heard the term MESD, and that's just abbreviated for moisture-associated skin damage. But what is it? Well, it is just a prolonged or continuous exposure to moisture on the skin. And that exposure to moisture for a long period of time, doesn't matter what that moisture is, effectively damages the barrier function of that skin. Okay, so we get overhydration, that skin's really moist, and we often refer to that as kind of maceration in kind of healthcare. So we get that overhydration, we get that maceration of the skin, and it's that epidermis that we see this damage. Okay, so that top visible layer of skin that we can see. Okay, and the top of that epidermis, I want you to remember the stratum corneum, and we're going to talk a little bit about that in the next slide. But once this overhydrated skin becomes kind of inflamed, eventually we'll see kind of erosions and breaks in that skin. And this is what we've commonly always known as moisture lesions, okay? These kind of moisture lesions, that moist skin can then lead to other complications such as friction and shearing. Now, I don't know if you're familiar with the term the acid mantle, but the stratum corneum that we mentioned in that epidermis, that top layer of skin, this is what we would refer to as being our kind of protective barrier on the skin. Okay, so it's called the acid mantle. It's called that because it is an acidic pH on the skin, and we get that from sebum, an oily substance that's on the skin that coats our skin from the sebaceous glands. Okay, and on the skin, we've got a pH that's quite acidic that can kind of get rid or repel and kind of protect that skin from any microorganisms. Okay.
Emily, I'm really sorry.
Yeah.
I'm going to stop you for a second because someone has said they can't see the PowerPoint.
Oh.
So is there anybody else that can't see the PowerPoint?
Oh, you can now. Okay.
You can now. Okay, lovely. Right, thank you.
Sometimes it's just on like a mobile phone and things, isn't it?
It is.
Brilliant. Just let me know if anyone else can't see it.
Will do.
So that pH is about 4.5 to 5.75, okay? And as you can see here, I have the point there. That's quite an acidic pH, hence the name, okay? What we have when we have moisture that sits on the skin for a prolonged period of time is that we get that skin turn more of an alkaline base, okay? That pH is disrupted and that skin doesn't like being in that alkaline state. So what we see happen is that skin just erodes and breaks eventually, okay? So we get those patches of skin loss that we're going to talk about. So MESD, it is an umbrella term, okay, and it covers 4 pillars of moisture-associated skin damage. These are different dermatitis, okay, and the difference between them really is what kind of moisture causes that dermatitis. We're going to look at incontinence-associated dermatitis first, and we're going to really focus on that today through the session because it is the most common type of moisture damage that we do see. So what does it look like? Well, incontinence-associated dermatitis is often referred to as IAD, and I'm sure we've all seen it out in practice. It is the most common type of moisture damage. It is due to exposure to incontinence through either urine, feces, or the two together, okay? So those episodes of incontinence will sit on the skin and cause a breakdown in the skin. But how does that kind of chain of reaction start? Well, typically we see kind of widespread blotchy erythema. And erythema is really just that medical word for that redness that we see in the skin when there's been some kind of injury or trauma to the skin in an inflammatory response, okay? So again, with the pointer, I'm just going to show you and draw your attention to this photograph at the top. This is a really good example. If we look at that surrounding skin, it's very blotchy. If we ignore the actual patches of skin loss or the moisture lesions, and we just looked at that surrounding skin, it's very patchy and kind of red, isn't it? And this is typically what we see in moisture damage because that urine or that feces is soaked under the skin in different areas, okay? So we're going to have blotchy, widespread erythema, and then potentially we're going to see maceration developing. Now, we've all probably seen maceration when we've been in the bath for a bit too long. Say we've fallen asleep in there and our fingertips and our toes go almost lighter than our skin tone and they go really wrinkly because they're so wet And this is just what maceration is, okay? And again, we can see it really in the center of that picture where we've almost got those white patches of skin present, okay? So that's that overhydration of skin. And then unfortunately, if we kind of see more progression of this, we're going to see some patches of denudement, which is that skin loss. And this is going to be pretty superficial, okay? The only time it may go to a partial thickness erosion, which is similar to your kind of category 2 pressure ulcers depth-wise, is if we've got a severe case of moisture-associated skin damage or maybe an infection present, okay? So it's going to be superficial, and it's also going to usually be quite irregular in shape when we have these kind of wounds. So again, this photograph is brilliant. You can see if you look at those wounds separately, they're all quite jagged in edges, and that's again with that kind of feces or that urine mirroring on the skin. It's a bit like if I poured some water on the table, it would scatter, and it's like that on the skin, okay? You also may see damage in linear skin folds, and that's like this photograph here. So we've got the natal cleft, we've pulled that skin fold apart, and what we've got is a split-like break in the skin, so that epidermis is no longer intact. And that's just due to that skin fold holding all that moisture in that crevice, okay? So do look out for this. Make sure you're checking skin folds, especially around that natal cleft for this, okay? What we may see is some leakage of kind of serous fluid or bleeding potentially, but we're going to discuss a little bit later on in the presentation about how we can mitigate the risk of kind of bleeding when we're cleansing patients, okay? But where are we going to see these? Well, we're going to see these around the buttock area, aren't we? That's where we typically see them. But we can see it around the perianal area, potentially the genitals, the natal cleft, groins and thighs, especially in my nursing time, I've seen that patients who are on diuretics can pass high volumes of urine. And this can then mean sometimes patients are in wet clothing. So you may see moisture damage down the backs of the legs and the groins as well. Okay. But one thing I want to draw your attention to is that they can be on a bony prominence. So they could be around this kind of sacral area, which does confuse staff. I have definitely mistaken moisture and pressure in my nursing time, and I won't be the last because they do look very, very similar. Okay, so if you're not sure, you can always reach out to your tissue viability service as well. Skin tone cards. We have a brilliant kind of skin tone card that we've brought out in the last few years, and it's all about that early recognition of any redness on the skin, so that erythema that we spoke about, okay? So we've got this skin tone card to help identify early signs of any skin changes in patients with darker skin tones, okay? What we don't want to see is a wound like this where we've missed that early signs where the skin was a little bit irritated, but because we couldn't see that erythema, we've missed it, okay? So what we've brought out is this card that we can check the patient's kind of skin tone, baseline skin tone, potentially somewhere like under their armpit, okay, where it's not in indirect sunlight. Then we can monitor those at-risk areas to monitor for any changes. And what we might see is a darkening of the skin tone, or we may see a lightening of the skin tone if we have that macerated skin, that overhydrated skin, okay? So we do have letters along the top, numbers along the side. You could say that patient's skin tone was around C2 and now it's B5, for example. Takes the subjectiveness out of it, and you can then write that in your notes. You've got a way of measuring that kind of change in the skin. It's a brilliant tool, but please don't use it in isolation. We do need to be getting our hands on the patient, feeling that skin. Does it feel warm to touch? Does it feel swollen, boggy or firm? Does it just feel generally different to the surrounding skin? Or is that patient, if they're able to, actually telling you that there's problems, that there's itching, there's burning, it just doesn't feel right? Or are they showing the signs that they're trying to scratch in their pad? That's a very telling sign that there could be some mild irritation going on there, okay? But we'll share some links at the end that you can get one of these cards for yourself. Especially with IAD, so that moisture damage from urine and feces is going to be particularly painful for patients, okay? And if you think about it, our urine and feces is waste products, so they can be quite corrosive. They're getting rid of a lot of kind of salts and different various waste products, which can really irritate the skin, especially if it's inflamed or we actually have some patches of skin loss through that epidermis, okay? And the reason that they feel this kind of burning sensation is because we've got a nerve ending here that you can see with my pointer. This is the base of the nerve ending in the dermis layer of skin. But the tip of that nerve ending is in the dermis, epidermis, okay? And we call this the dermal epidermal junction. So as that epidermis erodes, we get that breakdown in the epidermis, that stratum corneum. We then find that the nerve endings are firing off. So patients experience a lot of burning and itching with moisture-associated skin damage. So what are the other 3 pillars of moisture-associated skin damage? We've talked about IAD, our incontinence-associated dermatitis. Well, some other ones to look out for is these 3 on the screen, okay? So we've got peri-wound moisture-associated dermatitis. We probably see this quite a lot if we are community staff, okay? Wet, heavy exuding wounds, but it also can come from an area of inflammation as well. So if you think about patients with heart failure or leaky legs, they may get really severely macerated legs, and essentially this is just the same, okay? So we've got a lovely leg ulcer here. This skin around here was all healthy at the top as well, but we can see how macerated and overhydrated that skin is, okay? Soaking wet. So again, we can be using barrier products to strengthen and mature that skin so we can protect it from that moisture so we can get these wounds healed, okay? Peristomal moisture-associated dermatitis is essentially any effluent that comes from a surgically formed stoma, okay? So that could be a colostomy, like in this photograph here, where we've clearly got some kind of fecal matter that's came out, sat on the skin and broke the skin down. But another common kind of cause of this could be the fact that the bag was too full, and if the base plate has been cut too big, can sit on the skin and cause issues in that sense, okay? But other types of stomas as well. So we've got things like PEGs, tracheostomies, urostomies, any surgically formed stoma. This can happen too, okay? And it can kind of cover that 4 centimeter diameter around that stoma. And then the last one is intertriginous dermatitis, which might not be a word that you're very familiar with. You may have heard intertrigo, but all it is a posh word for a sweat rash, okay? So what we find is we get an inflammatory response from a skin fold, from a buildup of sweat, okay? So that heat, that sweat, it can't circulate in that trapped skin fold. And what we find is the skin breaks out in moisture damage. So we've got someone's leg and apron here. It's obviously started in both the groin and the apron and just spread out, okay? So really common in the summer months when we're all very hot and sweaty, especially when we're working in healthcare, but also look out for your patients with higher BMIs as well. They're very at risk of this. So it's going to be our first poll question. So it's just going to load up on the screen. I'll read out the question if you just pick your answer. So how is moisture-associated skin damage categorized? We've got grade 1, grade 2, or grade 3, irritated, excoriated, or broken, mild, moderate, or severe. So if you click the answer and don't forget to press submit at the bottom. The results will be shared. Has everyone had a chance to vote, do you think? Just another second. Okay, let's see what people have put. Okay, brilliant. So we've got most responses. We've got a few more coming in. Okay, so most of the responses have been mild, moderate, and severe, which is correct. Okay, and irritated, excoriated, and broken does make a lot of sense. It really does. And obviously your grades are your pressure also categorizing. Okay, brilliant. Thank you so much for that. So mild, moderate, and severe. This is how we categorize moisture-associated skin damage. And here you can see 3 photographs of incontinence-associated dermatitis, but different levels of that damage, okay? And you'll notice that we've got a skin damage meter above there. Please do look out for these on our products, our Mediderma S and Mediderma Pro products, because they will guide you what this product is aimed to be used on, okay? But mild damage would be erythematous skin, so that red skin that we've spoke about. The skin might be quite dry, okay? Very common, especially when pads are being used. We can often draw out the moisture in the skin through those pads. But the main thing about mild damage is that the skin is intact, okay? The skin is intact, but it is at risk of further breakdown. And we can see this photograph here. The skin looks a bit red, and you could get back to that at the end of the shift or the next day, and that skin could be broken where that epidermis is no longer intact. Okay. So as soon as we have a break in that epidermis, we then go to moderate. Okay. So even if it's just one isolated area, it would become moderate. So we've categorized that as a moderate amount of redness, and we've got less than 50% skin damage. So that's that broken skin, that epidermis is no longer intact for less than 50% of that affected area. Okay. Over 50% would be severe. Okay. And I just want to draw your attention to this photograph of the severe damage. Sometimes that damage is just meaning the whole top layer of skin has been stripped, unfortunately, due to that prolonged exposure to moisture on the skin. We've just had that top layer of epidermis totally stripped away. We're not always looking for distinct wounds or moisture lesions as such. It can just be that that whole top layer of skin is off, like in this photograph here. Okay. So I would expect you'll definitely see some bleeding and oozing in these severe stages. Hope we don't get to this point, but you may also see some in the moderate stage as well. Okay. What we're going to talk about in that cleansing regime is about how we can try and reduce that risk of bleeding. Okay. So let's talk about prevention now, okay, and why it's kind of so important. Well, really, as clinicians, we should be following this approach in our everyday kind of practice. Prevention really feeds into health promotion for all our patients, not just in skincare, okay? So if we've got healthier lives, we've got a healthier society, and we've got less complications, and that means less strain on our National Health Service, okay? So we really need to adopt the same approach for our patients' skin. And by preventing any skin complications, we are saving the NHS money daily, okay? We're saving the money on length of patients in stay, how long they're in that hospital for, or how long they're required on that community caseload, okay? It actually reduces your kind of nursing time as well by reducing visits or how much time that you're spending on that wound care, on that moisture damage, okay, or that intervention that's required. But it also means that it reduces the risk of complications such as pressure ulcers, okay? And although we don't have numbers for how much MASD costs us as a National Health Service per year, we do on pressure ulcers. And we're going to talk a little bit about how the two kind of develop together sometimes in the next slides. But pressure ulcers cost the NHS £3.8 million per day, which is crazy. That's around 2.2 billion per year, okay? So really what we need to be thinking about is how we can reduce the cost for the NHS by feeding into prevention, but also for our patients as well. So we're talking about cost, but really as well, why should our patients have to suffer with this when all of this is avoidable harm? Okay. So I just want you to look at them photographs and think, how can we prevent this? Because sometimes it really does start as a mild damage, okay? But it does progress to this stage. And if we just intervened before there was any signs, we may have avoided this in the first place, okay? So we never mean to inflict any harm on these patients, but we can avoid this. I appreciate we can't always control the state that we inherit patients into our care. So sometimes they might be admitted into our care or onto our caseload with skin like this. And I sometimes we cannot do anything about that, but try and treat this wound. But we can prevent, okay? So we're really going to focus on that on the next few slides. So prevention. Really, skin damage can develop from as little as 15 minutes of contact with moisture on the skin, which is really, really quick. So if we start seeing episodes of incontinence, we need to be thinking, let's just get that barrier cream, that barrier product on the skin that's readily available before we see any signs of damage. Despite the level of damage, patients can still feel a lot of itching, burning, and kind of pain. So we want to prevent that from developing from that mild stage. So if we can do it before there's any signs and symptoms, we're going to try our best to do so. What we might find as well is that if patients are in pain, they're going to kind of struggle to comply with cleansing and treatment. Okay, so for example, look at this patient here that we've got a patient with a deeper pigmented skin. And what we have got here is scarring. So they've had some moisture damage that is healing. It's not fully healed yet, but what we're getting left with is some post-inflammatory hyperpigmentation, okay? And it looks like it's healing, starting to heal, but we're still a little bit exposed. How do you think this would feel, trying to sit and mobilize and sit out in a chair for your rehabilitation? Would you want to comply? Would you want to sit on this because it's still not healed? The risk we have as well with these kind of scarring is that the strength of that skin only develops back to around 70%. So we have risk that that kind of fragile skin, that scarring, will break down again in the future. So we've got the risk, a much heightened risk of moisture-associated skin damage or pressure ulcers in that affected area again. So pressure ulceration. IAD, unfortunately, is a recognised risk factor of developing pressure ulcers, okay? But the two can coexist in one individual, and that is a bit like this photograph here, okay? So what we can see in this photograph is quite a telling sign of moisture. We've got that kind of mirrored effect on the buttock where we've probably had some kind of pad use or some moisture sat on that area. But now what we've got is some devitalized tissue in the wound. So we've got some slough, we've got a little bit of necrosis in there. And that is not typical of moisture damage. You will not see that in moisture in isolation. So what we've found here is that we've got moisture that has then developed into pressure. And the best way to understand how this kind of happens is that if we've already got a kind of inflammation to that area, potentially a chronic inflammation if this has been a long-standing issue, we've got reduced blood flow to that area, okay? So what we find is that we get pressure-induced ischemia very, very easily. We also find that really we get a deeper and faster pressure developing, because if you think about the skin, that epidermis is kind of aimed to be, survive in the outside world, and that's what it's designed for. So it's designed to withstand pressure to some degree and kind of fight off that external environment of microorganisms, etc. But the dermis layer, that layer underneath the epidermis, is not. And what we have here is the dermis layer of skin showing. So putting pressure on that, a bit like a plum or a piece of fruit, if we took that skin off, if we put pressure on that bit of fruit, we'd create a wound or a cavity, wouldn't we? Because that inside of the fruit is not meant to be exposed to the outside world. And this is what we typically see when moisture is there, okay? So really be careful. That wet skin is also very at risk of friction and shearing. So moving patients up the bed, please do use slide sheets and kind of the correct moving equipment so we can kind of really mitigate the risk of pressure ulcers developing in this way as well. Infections are another complication, unfortunately, of moisture-associated skin damage, which we can prevent by not getting to these later, more severe cases of moisture damage. So secondary skin infections can really develop for a couple of reasons, really, and we've already kind of touched on some. But what we find is that we've got that skin barrier disruption, so that acid mantle is no longer intact. It cannot fight off those microorganisms from the outside world. So therefore, we really kind of let in any pathogens, any microorganisms, and they can take hold and infect that skin, okay? Because it's a really lovely warm environment, it's wet, it's probably around that kind of warm pad area, bacteria and microorganisms just thrive, okay? They really love a warm, nice environment so they can just proliferate, especially those fungal infections, okay? And what we tend to see is the pH change from that urine or feces, and that allows further growth of these microorganisms. What we do find as well is that because we've got that inflammation, we've got an impaired immunity. So we haven't got that kind of triggering that kind of white blood cell response that we probably would usually get because we've got that inflammation that's been there for a kind of a long-standing time. Okay, so you can't really get rid of that infection as easy. And then lastly, we've got a disruption in that normal kind of skin microbiome, if you will. And again, this just means like bacteria and fungal, like candida can just really thrive in these areas. They find it very opportunistic, especially in those intertrigo areas, those skin folds. So by preventing that kind of moderate to severe damage, we're preventing these infections from taking place. If we can get in there before that epidermis is compromised, we're then protecting that dermis layer and trying to reduce those secondary infections developing. And by doing that as well, we're also really doing our bit to help kind of reduce this antimicrobial resistance that we're all seeing. And it's a strong kind of focus at the moment. I'm sure you've all heard about it. AMR is really a global health concern. And it's because, for anyone who doesn't know what this is, it is really an antimicrobial resistance. So a process that the microorganisms are adapting to our antimicrobes, okay? So antimicrobials that we're using, these bugs are adapting to them. And it's just due to the fact that we are overusing them and using them inappropriately sometimes as well, okay? So what we need to do is kind of follow that antimicrobial stewardship, which is a real movement to use any antimicrobials properly, okay? So using them wisely, ensuring that they should be prescribed and monitoring the use when they're on as well, okay? And this does just cover a whole wide range of different treatments that we'll use. So not just your antibiotic cover, okay? So I think that's the first thing we think of is those IV, those oral antibiotics, we're using them too much. But it is also topical antibiotics as well. It's also your antivirals, your antifungals, which we've just spoke about, those fungal infections developing and moisture-associated skin damage. They're being overused as well. But it's also your antimicrobial dressings and your antiseptics. So that's even what you cleanse those wounds with. Okay, we can see that number on the screen. It's very, very daunting. 4.95 million deaths annually in 2025. It's a big word. It's a big number to get your mouth around, but it just shows that the trajectory is increasing as well. So we're seeing potentially around 10 million deaths per year on the rise is what we're going to see, which is really, really scary. So we need to do something about this. We need to think about, as practitioners, how difficult our job could be. So even cleansing wounds, leg wounds in the future, even a general cut. Imagine if your loved one or yourself got a little cut with an infection in, it might get to the point where we struggle to treat that infection, okay? So we need to do our bit. We need to be preserving our silver dressings and so forth, because we're seeing more and more evidence arising now that even silver dressings are kind of at risk because these anti-organisms are kind of adapting to these silvers as well. So we need to be kind of protecting them. We haven't seen anything yet around Manuka grade honey that we use, but I think we'll see it coming in the future. So please do kind of stop and think, do I need these silver, these Inagene dressings, and also this honey that you're putting on the wounds? Make sure you're swabbing those wounds and getting medical advice as well, okay? So what's our call to action as clinicians? Well, I've now proposed that we put prevention before mild, moderate, and severe. And I think you all will do the same when you hopefully leave this session at the end of the day, okay? What comes before mild? We need to be thinking prevention. Prevention rather than cure. And we're following that NHS strategy, okay? So what we need to be thinking about is a patient like this, who's got no redness, no erythema present, the skin's looking a bit dry, but the key factor is they've got some risk factors. They may be incontinence of urine, for example. What are you going to think? I'm going to think, right, I'm just going to prevent and implement a barrier cream as a part of their treatment, okay? Let's prevent it getting to this stage and definitely further down this end. So with this photograph, we're going to release another poll question. Let's wait until this comes up on the screen. What would you do for this skin in the picture? And what if the patient was experiencing an episode of incontinence? Would you do nothing at all? Would you apply an emollient directly to the skin? Or would you apply a barrier cream? Just give you a few minutes there to answer. That's it. Don't forget to press submit. Got some answers coming in. Brilliant. Fab. Okie dokie. So, correct. Apply a barrier cream. And what I might say is that really with the emollient, we will talk in more depth. They do have their place, they will moisturize, but they won't provide a long-lasting barrier. Okay, and we'll touch a little bit more on that in the next few slides. So it would be the best option would be a barrier cream in this instance. So let's talk about those risk factors, okay? So what are risk factors? Well, we've got primary and secondary risk factors that I want you to think about. So when we're thinking about prevention, when we go out and practice, what are those alarm bells that will be ringing, okay? So your primary risk factors are the direct contact with that bodily fluid, okay? So they are your urine or fecal incontinence, your double incontinence, episodes of diarrhea, or frequent episodes of urine, okay? Those more indirect causes of incontinence are your secondary risk factors. So they're more things that might inhibit you to maybe potentially get to the toilet as such, or maybe kind of bring on that incontinence quickly. So poor mobility, for example, getting to the toilet in time, or not having the dexterity to kind of get your pants undone, for an example, okay? Medications may increase the frequency, or it might come on really, really sudden as well, things like laxatives. We've also got confusion or cognitive impairment. You might not know where that toilet is to go, or you might not recognize that you actually need the toilet. Critical illness or kind of acute illnesses can also affect that. So again, not knowing you need the toilet, or being able to, or not to be able to communicate that need as well. Okay, so you can understand how a patient can manage that condition really, really well with the primary risk factor. They may have urine incontinence, but they manage it really well. So their skin is well looked after. They've got a good skin regime, but they get unwell in an instance. So they become confused, they've got an infection going on, they've been admitted to hospital, and therefore they're no longer mobile and independent and able to kind of manage that incontinence. Their skin becomes a risk. Okay, the two kind of go together to then cause that risk of moisture developing. Okay, some kind of related conditions that you might want to think about, and again, how if their health status with those secondary risk factors change, they may begin to develop IAD. And that might be things like your Crohn's or your ulcerative colitis, where you've got that kind of fecal incontinence, that sudden urge to need to go, or your kind of urinary tract infections. Issues with prostate might be another reason. And we've all looked after patients with C. difficile, I'm sure. And again, how many times they are moving their bowels, it can be very explosive and sudden diarrhea. So again, they're the type of patients you really want to be thinking about. So let's look at some management strategies now. So we've mentioned about kind of skin regime, but what does that mean? Well, we're going to talk about the 3 steps that we need to think about. But what I want you to think about with good skin hygiene is really regular skin inspections. So I would say, at least as nurses, as qualified nurses, we should be, if we've got patients within our care in a 24-hour facility, we should be checking that patient's skin at least once a day. More often if we have really at risk or damaged skin especially. Okay, so I know we may have healthcare professionals in this kind of session, and they may have seen them more frequently, but I think it's always good as a registered nurse to be looking at that skin as well, just to make sure you've seen it yourself. And where we want to kind of manage incontinence where we can, we will do. Okay, so that might be the use of incontinence pads, things like sheaths for men. They're a really good toileting aid in the sense of that if we need them for overnight, they're a brilliant resource to use. Okay, but what then I want you to think about is cleansing, hydration, and protection. So with cleansing, we want to be thinking about cleansing that skin with something pH balanced. So if that is a emollient in water, in warm water, as a soap substitute, or if that's a pH balanced cleanser. Okay, what we're finding is that more evidence is suggesting that pH balanced cleansers are the way to go, and that is from a point of view as us as the clinician. Saves our back for moving and handling, and also if we're in that community sector, it's carrying that ball for infection control. So we're moving more towards pH balanced cleansers. Okay, but what I do want you to avoid is traditional soaps. And what I mean by that is just them lovely bars of imperial leather and things we all bring in. Okay, because they're kind of perfumed and they have a lovely smell, they alter that acid mantle that we spoke about. Okay, so that natural skin barrier is compromised. It alters that pH because there's a perfume and an alcohol in the soap. So we'll avoid them. especially if we've got risk factors and especially if we have damaged skin. We want to be avoiding them at all costs. We're gonna pat to cleanse. We're not gonna rub, especially if we've got damaged skin, okay? Because we don't want to cause any more trauma, and we know that that skin's already very wet, so we don't want to push that skin and cause friction and shearing. We're going to either let the skin air dry, or we're going to, again, just pat the skin dry, okay, with a towel or a dry cloth. Then when the skin's fully dry, we're going to move over hydration. And the benefit of using a barrier cream is that you've got hydration and protection all in one product, okay? If you do need to use an emollient to hydrate the skin first, that's absolutely fine, but there's no need to do that with a barrier cream because it does the two together. If you've got patients with overhydrated skin and those moderate and severe levels of skin, chances are you are not going to need to hydrate that skin because it is already very, very moist. So we'll just go straight in and protect that skin with a skin barrier. It is a film option or an ointment. Okay. And why do we want lovely hydrated skin? Well, these two photographs show what skin is like when it's hydrated and when it is not. So if you think about how easy it would be for bugs, microorganisms to get through this bottom photo, this dry, cracked skin, it's easy for them to maneuver through. So we've got a lovely hydrated skin. We've got lovely, robust, full of kind of hydration and moisture, and nothing can get through those skin cells. It makes it a really kind of strong barrier that we can protect our skin from infections. So dry skin is more at risk of infections and moisture damage in general, okay? But if we do have any mild damage, so that erythema, that redness, and we have a bit of an itch, it's really going to soothe that skin. It's going to hydrate the skin, hopefully take away some of them symptoms for the patient, okay? So really think about hydrating the skin, but we can do that both in one and protect with a barrier cream. So this is your third question. It's going to load up on the screen. Brilliant. So what does wash-off resistance mean? Does it mean provides a barrier protection on the skin that cannot be washed off by incontinence? Or does it provide a barrier protection by providing a silicone barrier that is not washed off by cleansing or any type of moisture challenge? So select your answers. Brilliant. We'll wait for the results to roll in. Fab. That's so most of you have said that it is the second, which is not to be washed off by moisture challenges or cleansers. So that's brilliant. Okay. And that's because wash off resistance is essentially preventing any moisture. So that means cleansing or that moisture on the skin to come off. Okay. That silicone barrier will stay put. So let's look at barrier creams and emollients side by side. So barrier creams are silicone based. So they will provide a silicone barrier on the skin, which provides barrier protection. We know it's wash off resistant through cleansing and through that moisture challenge. It will hydrate the skin, but it will also keep out that external moisture. Okay, so that moisture that we want to keep from touching the skin, that urine or that feces. We only need a small amount. Less is more with barrier products because it's silicone based. We don't want to stack up that product too much. And it will treat and prevent moisture associated skin damage. But with emollients, they are water or oil based. They're meant to be a medical moisturizer or kind of a soap substitute. So what we find is that you can apply these really liberally, but it does mean that as soon as you cleanse that area, that emollient will be washed off the skin. It can be argued that because of the oil-based kind of content, emollients can provide a little barrier on the skin, but not for a prolonged period of time. So we don't want to be using this as a part of our kind of treatment or prevention of moisture damage, because what we will see eventually is probably that moisture being drawn into the skin because that kind of oil helps draw moisture into the skin. Okay, so we need to be careful with that. So any signs of risk factors of moisture damage, we're going to be using a barrier cream. We have a wash-off study, and we're going to pop this in, and there'll be a link on one of the last pages if you are interested in looking at our barrier cream and its wash-off resistance. We've got this study that we will share with you at the end. So this is our kind of range of products, our Mediderma products. And this is a total barrier protection. So we've got cream, films, and an ointment and cleanser. And as we've mentioned earlier on, there's a skin damage meter on the products so that it will identify which product is aimed for which level of damage. So we spoke mostly about our Mediderma S Total Barrier Cream today, but we have got that Mediderma S film and our Mediderma Pro ointment and cleanser for those moderate and severe damage as well. The aim is that if you're not happy, that you want to step up a product to try and make that skin heal faster, you can do so, and you can step back down when you're seeing an improvement in that skin. We've also got our skin moisture alert reporting tool, and this is our smart tool. We're really proud of it, and we've worked alongside NICE guidelines to endorse this. Okay, so what you'll notice is that there's no product endorsements within the actual table, but it is our products that we're talking about. You can be rest assured, and it goes into everything that we've discussed today about the 4 different types of moisture associated skin damage. So again, we'll have a link for this at the end. We've also got it in a small version that you can have on your lanyards or carry in your pockets. So if you'd like to click on that link there on the screen now, or we will have the link at the end. Okay, so a brilliant tool, and it makes it very handy that you can then have that in your lanyard or on your pocket. The skin tone assessment tool, again, there will be a link for this at the end. This is what it looks like, but just to also show you the back of the card and how you can actually see mild, moderate, and severe damage on different, on kind of deeper pigmented skin. Okay. So to summarize, we've talked about moisture associated skin damage, the acid mantle. We've defined the classifications, so mild, moderate, and severe, and the severities as well. And we have looked at prevention to avoid harm in patients. So how can we prevent, to prevent those infections, prevent those pressure ulcers and scarring, hyperpigmentation, and further breakdown of the skin, okay? So we're mitigating all that risk. We're also doing our bit to go and kind of follow that antimicrobial stewardship, reducing that resistance by trying to reduce those honey products that we're using on skin, and also our silver and inidine dressings. But it also means that we can kind of help and identify so that we can notice this damage before it becomes a problem for patients. And that's all through looking at those primary and secondary risk factors. Okay. We've looked at emollients and barrier creams and how really barrier creams can't be replaced. Emollients most definitely have their place, but barrier creams, when there's any moisture damage there or any fear of any moisture damage, we should be opting for a barrier cream instead. Okay. And lastly, we've looked at our total barrier protection strategy and how it can cover all the different types of moisture associated skin damage, even though we've kind of focused on IAD primarily today. Okay. So just due to time today, we haven't got time to go over the products and do a demonstration. But if you are interested, please do contact us via the emails that will be in the chat box and on the last slide. We're more than happy to organise some training for your area, and we'll point you to the right kind of territory manager or clinical lead. What we have on the screen is some kind of resources that you could also request we could bring along to these meetings. So we do have a prevention training poster if you think this would be a benefit for your area. Okay, so this could go up in your kind of office or on your ward, and it talks a little bit about thinking about a barrier cream morning and night for prevention. If you've got those risk factors, you're going to use that cream if in doubt. It'll hydrate the skin and it will protect the skin. And we've also got our cream discharge bags. So these are brilliant if you do have patients who maybe have had some moisture damage, or they again have those risk factors, and you would like to send them home with a sample of the cream so that they can then continue to use it to kind of protect their skin when they're at home. So these are 2 options of things we can bring along. They're definitely really good resources, and we've had some really good feedback from the discharge bags for patients. It means that they can take that prescription card to the GP and get that prescription on repeat. Okay, so if they want to continue using it as a kind of prevention, they can do. All right. Lost my cursor there. So thank you. Sorry, I've talked at you for a good 50 minutes there, but we're going to open the floor up to questions. I'm not sure if we've already got some in the Q&A. I'm going to pop you off mute there.
Yeah, that's brilliant.
Thank you.
Emily, thank you. That was superb. We do have one or two questions. We have a question from
Thank
Georgina
you.
saying, how long before needing to reapply the barrier cream?
So what we would tend to advise is twice a day or every third wash. So it just depends on how often that person is kind of incontinent. So if someone was incontinent 6 times a day, which is a lot, that would be morning and night. That would be twice a day, wouldn't it? So less than you think, honestly. I know as a nurse, I definitely have applied barrier products more frequently than I should have because you can't physically see them on the skin. So we always have that fears that if we can't see it, it's not there. But with it being silicone, it's wash off resistant, it's still on the skin. And actually, you're allowing that skin to kind of breathe and not stacking up silicone by putting loads of layers on. So less is more, morning and night, or every third wash. Sometimes it's easier just to stick to the morning and night for remembering.
That's brilliant. Thank you. I also have a question about saliva. Can saliva cause damage to the skin?
Absolutely. And it's never really been a mention in the 4 pillars, but most definitely. I always talk about it in terms of kind of peristomal damage because you think about tracheostomies. Sometimes you get kind of saliva from that. But also you might see it quite often in stroke patients as well, especially if there's any drooling, if there's any kind of folds in the neck, it may gather. So most definitely moisture damage can come from anything. It could be from some food if you left it on your chin for long enough. So don't want you to limit yourself to thinking that it is just exudate, incontinence. It can be anything. So most definitely you're right, saliva.
Brilliant, thank you. And we have a question from Carol, which is, I work in bladder and bowel and see a lot of moisture under the tummy tuck. What is the best to use?
Yeah, it depends on that level of damage, really. There's nothing to say you couldn't use a barrier cream if that patient likes that feeling. But if that skin's broken, I would say our Medidermis barrier film. It lasts a long time on the skin. It lasts up to 3 days if you're not cleaning that skin regularly. But if you're in doubt, you apply that only once a day. So again, really reducing your nursing time, how much you're having to kind of put intervention into that kind of wound. So yeah, I would say the film is always a great option for kind of that tummy tuck, that intertriginous area.
That's brilliant. And one final question, I think, which is, there's a lot of resources available for prevention of moisture damage. Why would you recommend Medidermis cream?
I think it's just because we have that kind of almost well, it is a non-sting product, but I think, and what the feedback we get is that it just feels like a normal moisturizer and it feels lovely on the skin, very, very soothing, and it's got a long-lasting wash-off effectiveness. And we've tested that in that wash-off theory. So you can be very confident that it's still on the skin, but it feels nice, it feels normal, and it just makes it a normal part of a kind of skincare regime. And that we always get very, very lovely feedback from it. So yeah.
Absolutely. And another final question. Why do you not recommend honey products? And the argument is this a more natural approach than actually using Medidermis? So.
Yes, because I know a lot of places will use honey products even for moisture damage. And it's not to say that, you can't do so, but I think what we need to be thinking about is, do we need sometimes those kind of more costly products if we're just intervening at the beginning? So if we're just focusing on prevention, we don't see any erythema, we don't see that breakdown of the epidermis. Why do we need honey at that point? We can prevent those infections and actually we can keep that cost down for that wound care sector, for your ward, because unfortunately they are more costly products because they're aimed at infection. Okay, so we can try and cut down that cost and also save them from our kind of antimicrobial resistance as well, if this is what we're going to see in the future.
That's brilliant. Thank you, Emily.
Thank
now,
you.
the link for your feedback for your certificates is in the chat box. So look where it says feedback for certificates and just click on that, and that'll take you to our feedback form. Once you've completed the feedback form, your certificate will be sent to you automatically. So that just allows us to gain some feedback on whether the webinar content was what you expected, whether it was right for your clinical area, and if there's anything else you would like us to do. So it's really important we have that feedback from you. And also you get your certificate at the end of it.